Hello, everyone. It's Laurie White once again, president of the Greater Providence Chamber of Commerce. And today we are celebrating episode number 118 of Chamber TV. And today our topic is all about healthcare. And we have a very special guest. Really happy and thrilled to introduce you all to Michele Lederberg. And Michele is the interim president and CEO of Blue Cross and Blue Shield of Rhode Island. How are you doing, Michele? Great to see you. Thanks for being here.
Good to see you, Laurie. Thanks for having me. I'm doing well.
Good. So how is everybody at Blue Cross doing in the wake of the pandemic? You're still working from home, I bet?
Yes, as you can see, my walls do not look like my office walls. So we still have almost all of our workforce at home. Actually, we have our 4 retail stores, which were remote, but opened up again in June, and there was a significant demand, and we have been following all sorts of COVID protocols for our retail stores. But basically, other than a small handful of people, everybody else is still working remotely, and it's amazing. It's been we were remarking, it's basically a year. On the 13th of March, we did a test day at home, and we've been home ever since then. And it's amazing, how our workforce has transitioned. We have accomplished just a tremendous amount in the last year, working remotely without missing a beat, and have spent a lot of time trying to make sure that we're properly supporting our workforce. And we have a largely female workforce. As you know, many people have school-age kids who are working, partially remote, or some all remote. And so we have done our very best for our workforce to recognize the needs that folks have and be as flexible as we can be. We provided stipends early on for materials or furniture that might be needed to work at home. We actually provided a caregiver stipend in the fall for folks who have school-age children that might need software or other things, and even elder parents. And so it's been a really interesting learning experience. And I think, what I have heard from our workforce, people are feeling really supported. So we are very, very, very fortunate.
Sure. Well, that's the number one question today in industry, is the whole notion of where does it go from here, and what is everybody going to do in terms of reopening and bringing people back, or is it going to be hybrid? Or some companies are saying, okay, well, we'll think about it in September. Others are thinking, well, maybe in June. Others are saying, well, maybe 2022. What is the magical thinking of Blue Cross and Blue Shield, and what can you offer in terms of best practices to share with other companies that might be looking for an interesting way to think about it on their own?
So definitely no magical thinking. If somebody knows the magic, we would love to hear it. We have a future workplace council that is comprised of a cross-functional group of associates in a number of areas. We have been meeting weekly since, I think, for the last 6 months. At this point, what we have said to our workforce is, at earliest, we'll come back either at the end of the academic year or when everybody has had the opportunity to get vaccinated, whichever is later. We may end up pushing that out further because we're starting to hear, in particular, summer camps won't be functioning fully. And as I mentioned earlier, we have a lot of associates who have kids at home. And we have surveyed our workforce early on and actually ended up moving about 100 people to permanent teleworkers. We're about to survey again to understand where associates are at. We recognize all the literature suggests that most workforces won't go back the way they were before, and nor will we. I fully expect we'll have a hybrid environment where a good number of our associates, if not the majority, are in the office a certain number of days a week. And so we're thinking about that now. What does that look like? What do we need to do to change our actual workplace? Because that's not how we were set up before. And we adopted our technology to be work for everybody who's remote. But once you have some folks in the office and some folks who are remote, you want to make sure that everybody feels included, that everybody can actively participate and collaborate together. And in some ways, that'll be more difficult when you have a hybrid work environment than when everybody's either in the office or remote.
Well, being in the health insurance industry yourself, question comes up about you're at the tip of the spear. What are you seeing in terms of trends that have come out of the pandemic, if you will? I know telemedicine has been a big thing. What else have you seen from a claims perspective that's of interest or significant from a cost acceleration point of view that you've noticed?
Sure. So telemedicine definitely is the use has expanded considerably, as everybody knows. We actually had been planning and had moved before it was required to offer telemedicine to our network. And for behavioral health, we recognize in particular telemedicine plays a critically important role in behavioral health, not just during the pandemic, but I think in Rhode Island, we know that there is a higher need for behavioral health services and an issue with access. And so that was just exacerbated by the pandemic. And so it's definitely a trend for the future. And we are continuing to ensure that we offer that and making sure that we compensate appropriately for that. It'll be a question in the future. What we saw is everybody went to remote and telehealth, all specialties went through telehealth. But sometimes telehealth, when it's safe to go back into the office, as it is in many ways now, is not always the best. For example, we know one of the things we did see is childhood immunizations dropped drastically. And so we have been working with the pediatric community to encourage our members to ensure their children get vaccinated. So that's really important. Emergency room services, on the other hand, are something that dropped during the pandemic. And I think what we believe at this point is some of those were services that maybe weren't necessary for the emergency department earlier, and maybe there will be a change in behavior because we know that there was some overutilization and some folks were going to the emergency room because it was convenient and easy rather than seeking care from a primary care physician. So I expect we will, not only Blue Cross, but nationally, we'll see a change in that. Many people early on missed primary care visits, and so we saw a substantial decrease initially in primary care, and then more telehealth use with primary care, and now it's dropped down again. I expect we have seen what looks like a number of deferred services that were starting to come back in the fall, and then dropped again when we saw the next wave towards the end of the year. We did see a big increase in claims for COVID at the end of 2020, much bigger than for our population we had seen in wave one. And I would suggest folks who are sicker, who are needing hospital services, but that has started to drop off again too, which we're pleased to see.
Yeah, well, that's the thing, that the trend is mirroring what the overall population is experiencing relative to new cases and the like. Wondering about some comments that you've made earlier about warning people that they should not forego, their primary care services. It's important, if you're sick or if you're having chest pain, to not be afraid to, go and seek those services. So I'm hearing you say that it's coming back a little bit.
It is coming back a little bit, and we are strongly, most primary care offices are back now, as we can see, and telehealth is still an available service, but we are definitely encouraging our members, seek care when you need it, particularly if you have a primary care physician. Make sure you call and get an appointment if there's something to be seen, and certainly for those folks who need behavioral health services. And we know there was a need in Rhode Island before, and it's much more acute now. I mean, that is clearly a trend that is seen nationwide. There is a little bit more access through telehealth. We have our local behavioral health providers, most of whom are doing telehealth services, and Blue Cross also contracts with a national telehealth provider to ensure some additional access. So critically important that people get the care, the screenings that they need.
I want to ask you about your tenure as president and CEO, acting president and CEO. Your predecessor, Kim Keck, who is certainly a good friend of all of ours at the chamber and yours as well, she has moved to head up the Blue Cross Plans of America, which is a very significant role. So you've taken over at a very opportune time in the history of Blue Cross and Blue Shield. Just wondering how it's going, and what are some of the things that you've been dealing with as president and CEO that is changing a little bit the trajectory of the company?
Sure. So I am really fortunate. There's a fantastic team of leaders at Blue Cross, and Kim was certainly the captain of the team, so to speak. But she had put in place an incredibly strong team, and we are all still at Blue Cross working collaboratively. I would say in some ways, I think the pandemic caused us to work even more collaboratively together, focused on our priorities of making sure we serve the people of Rhode Island and provide access to cost-effective care, and that work is ongoing and has not changed. And actually, some of our work has become even more pronounced as we've seen these, many people have talked about the twin pandemics. We had the first, the pandemic virus that hit Rhode Island, and then with the deaths of Breonna Taylor and George Floyd, the recognition of the systemic racism that exists. And Blue Cross has really been focused on addressing health equity and continues to focus on that, and addressing social determinants through our Rhode Island Life Index. We surveyed last year, and actually as Kim Keck left for the Blue Cross Association, we were announcing shortly before the results of our second, and now we are working on our third Rhode Island Life Index survey for early this spring. That work is underway, and in fact this year we will be partnering with community organizations to make sure that we are able to survey some of the immigrant communities who don't speak English, making sure we're capturing that. So that work is definitely underway. We had announced last year our work in the area of affordable housing. We are continuing to focus on that work, and are working on partnering with some organizations for some of our most significant grants that we'll be announcing in our history. So that is critically important. We are continuing to work with our systems of care to ensure that we're aligning our incentives with their incentives, so that will help over time lead to more cost-effective care that also leads to better outcomes for our members. And that was work that was started actually before Kim arrived, and we are continuing to spend a lot of time on that. We opened up new health centers with Oak Street Health shortly before the pandemic. And so we continue to work on ensuring that those health centers, which really provide a unique type of care for our sickest Medicare members, are open, and that our members understand that their services are available and familiar with them. That work continues as well. We were really fortunate even in the midst of the pandemic, Care New England, we came back to us and making sure for our customers that we provide them a seamless experience and provide them access to care. So we are continuing to focus on the work that we have underway relative to serving our customers.
You have been with Blue Cross since 1999 or thereabouts. You have a distinguished history as a healthcare practicing attorney, and you've seen so much during the course of your career, Michele, relative to trends in healthcare and ways in which issues, and you mentioned the social determinants of health, really play a role in what happens from the point of view of an insurer and how it becomes embedded in the cost structure and some of the things that the health insurance community is doing to get healthcare costs under control. So if you think back to when you first started at Blue Cross in 1999 and thinking forward to today, what do you think is the biggest difference, the biggest trend that you've seen that's remarkable?
So, I guess a couple of things. First, like you were mentioning, social determinants. I mean, it's been a long, long time in coming, but I think recognizing the whole person plays a role in somebody's overall health. I think for many years, there was an assumption that somebody's health is determined by the health care they receive. Instead of really recognizing, and there's been a lot of research done that actually the outcomes of your health, the health care you receive is like 20% of that, maybe a little bit more. And the social environmental factors that impact a person's life have a much more significant impact on their overall health. And with that recognition, the work that is being done to kind of integrate somebody's environmental and social factors into the care they receive. So addressing, for example, language barriers, access to healthy, nutritious food, and understanding if somebody has that access, because people make trade-offs. Do I pay for my medication or do I pay for food? If somebody is not living in stable, safe housing, how can they focus on their healthcare needs? So that's been a huge shift and something that we are really proud as an insured that we are focusing on and investing in. I think for many years, our philanthropy, and Blue Cross is an incredibly philanthropic organization, and have been focused on many years of access to care for the under and uninsured, and childhood overweight and obesity and activity, but kind of that ran almost off to the side of our work as a health insurer, so to speak, and how we were thinking about the delivery system. And now we are working with our provider partners to think about how do we share information and help fund things around whole person health. And I think that's going to make a huge difference overall in helping the health of the population in Rhode Island. And I'm really proud that we are an important component of that.
So I think what you're saying is to the root cause of what some of the drivers of healthcare expenditures might be, playing a more active role in trying to moderate that and modulate that, as opposed to just simply writing checks and paying claims.
Right, and recognizing that. And I do think another trend has been, and this goes with that, is, it used to be kind of insurers paid for whatever services were rendered many years ago. We were a claims payer. And it's been an evolution over time for us to be more of a partner in many ways with the health systems and the other providers that we have contractual relationships with, recognizing our incentives need to be aligned, and we need to help them through financial wherewithal, get the systems in place and access to the data that they need to better manage the overall health of the populations, the members, the patients that they serve.
Sure. Well, the the advent of data analytics and all of the various tools and algorithms and artificial intelligence and the like has really given not just the health insurance community and the health community the data and the tools and the insights they need, but it's really something that all companies have really taken advantage of, and it's been a game changer, I imagine, for for everyone, including Blue Cross.
Yeah, absolutely. I mean, when you think about, there is the Office of Health Insurance Commissioner, through executive order with Governor Raimondo, when she was here, put together a cost trends steering committee that's looking at a cost growth target. And one of the first reports came out last year where they were looking at data in what we have in Rhode Island, which many states do, an all payer claims database, to see what is driving the increase in healthcare costs using data, and determine that in Rhode Island, pharmacy price increases are, over 50% of the contributor of the cost increase, medical cost increase in Rhode Island. So that's, we wouldn't have known that before.
Mm-hmm. So you're talking about the healthcare cost trend index. I believe it's somewhere around 3%. Is that right?
The target, the target is 3.2%. That's the goal.
And that is said to be, a goal for all of those participants in the healthcare system, all of those provider systems, whether they be nursing homes and healthcare facilities, hospitals, primary care, standalone offices, ancillary services, tertiary, and the like.
Yes, it was a cross-functional group of folks that signed on to it. It's a somewhat aggressive target, but really important if we are going to slow the growth of healthcare costs over time. And so it starts with understanding the data and then acting on what we can and working together, which that's the great thing about Rhode Island. It's a small state, so we all know each other and can all work together.
Well, what's interesting about data is, we throw out statistics, but unless we put it in context, we don't really know if it's good or bad or indifferent. So is 3.2% as a cost containment threshold? How does that compare to what it had been in the past, or where you think it needs to be going forward?
So a 3.2 is going to be hard to achieve. It really is. And in part, I think it's that, changing of the way that healthcare is paid for over time. And it includes things like pharmacy, drug costs, which, in Rhode Island, we don't really have control over. And there has been some legislation introduced this year. And I know there's conversation at the national level, both and also in Rhode Island, about drug costs. That's a big component of that. And then also, looking for how healthcare services are paid for. If you pay for every service that's received, that gets to be expensive. So 3.2 is an aggressive target, and it will be difficult to meet. And, the goal is over a few years to get there.
How does hitting the target impact premiums that employers pay?
So it's the cost growth target is different than the rate increase because there are other factors that go in there. I mean, our goal is to limit the increase of premiums over time. And the way that we do that, the biggest portion of premiums is healthcare costs. So if we can reduce the cost of healthcare growth by entering into things like alternative payment arrangements with providers where you're not paying for every service rendered, that certainly will help over time. But the goal is to limit the cost increase, and then you have to actually limit the increased medical costs, because that's what drives premium growth.
What are some of the reasons why pharmacy costs are exploding so much? Is there something fundamental about Rhode Island's population that's over-reliant on prescription drugs, or is there something else at play here?
It's not the utilization that the cost trend data determined. It's actually the cost. And I think it's a number of things. Specialty drugs obviously are exploding. Those are very expensive. I think in 2020, there were like 4 new specialty drugs in the pipeline. And for 2022, it's something like 23. And those are the really expensive biologics. I think pharmaceutical companies, and you've read it in the national news, the cost of drugs, even drugs that have been in the market a long time, are going up exponentially. And there is data to suggest often it's not supported price increases. And, I can't rationalize how it is that they can suggest that a drug last year cost $100 or $50, cost $55 this year. But that is, legislation, both in Rhode Island and in other places, that, there are these suggestions that it be tied to something external and that there be penalties put in place for unsupported price increases, because it's definitely a concern.
The issue of coordinated healthcare in Rhode Island is certainly a big issue, and one of the biggest stories that's emerged recently has been news that Care New England and Lifespan and Brown University School of Medicine are interested in and have applied for permission from the state and from the FTC to consolidate under a single integrated entity, with the belief that keeping it local, keeping it not-for-profit, and being able to invest and not duplicate services is something that's really going to benefit Rhode Islanders for the long term. Interested from the payer perspective, from Blue Cross's perspective, no doubt you've been following this with great interest and certainly with great granularity. So what is the view of Blue Cross relative to this proposed application?
So for us, jury's still out. I get, we understand the concept of a single integrated academic medical center in concept. It's a great thing, but the question is for us, and as we represent our members, generally speaking, the literature suggests that hospital mergers, particularly in tightly concentrated markets, result in higher costs and not improved quality. And so the question for us is, what will, if these Care New England and Lifespan are permitted to merge, and then Lifespan has announced they're purchasing Coastal Medical, I think they announced last year, so that'll be 50% of the primary care physicians in Rhode Island. How do they intend, what will the things that they will agree to do to ensure what has been suggested by all of the literature doesn't happen here? So how will they ensure cost doesn't go up? What will they do to help ensure Rhode Islanders have better quality care and continue to have necessary access? And then equity is an important piece of that too, right? And so we have had the good fortune, I have had the good fortune in many forums as it's getting discussed, to ask questions of Tim and Jim, and I get to meet with them on a regular basis, our leaders do. And we have said to them, it would be great to know what are the things that they are going to agree to do to ensure, cost, quality, access, and equity, which are the things that they are both talking about. And I am told that sometime in the near term, they will tell us what those are, and that will help us formulate an opinion on whether we think it's a good thing or we're seriously concerned. because, you know, I think we do have an obligation as the largest health insurer in Rhode Island to ultimately take a position, but we just don't have enough information at this point. And we are definitely interested in being part of the conversation and interested in learning more. And we are doing our own analysis internally, of course, and have hired some of our own experts to help us understand what are the things that have worked nationally to address these issues.
To that end, do you anticipate that you will indeed be taking a position and you will enter a position into the record? And when do you think that might be? And any thoughts on which way you might be leaning at this point?
So I can't say when it will be because they haven't even filed their applications with the state at this point in time, but we will definitely, I know there will be opportunity for public comment, and I am fully expecting that both the Department of Health and the Attorney General will ask us our thoughts. And so once we have an opportunity to see what it is they file and hear in particular what are the types of things that they will do to ensure that costs don't go up, because if costs go up, that means premiums go up, or even for all of the large self-funded groups like municipalities in the state, healthcare costs increasing will crowd out other expenditures. So when we know more, we'll be better informed and able to express a point of view. So hopefully in the next couple of months.
So this memorandum of understanding that's been executed among the parties is really interesting. It's different in that it now includes Brown University and their academic medical center, but it's not unique in that we've been down this path at least a couple of times with proposed consolidation of the two entities. So what in this memorandum of understanding gives you the notion that it's going to be different this time potentially?
You know, they're talking about different things. You know, a new cancer center, a number of other things in terms of better integration of care. Certainly, Dr. Babineau has and Dr. Finale have talked about one electronic medical system. And a number of other things. But, you know, until they actually file that application with detail, I don't think that the memorandum of understanding gives us enough sense at this point. But I know they're passionate. I know that they have a vision of how it's going to be different this time. And we are really looking forward to seeing and hearing the details of precisely what that looks like.
What specifically are you asking them to put guardrails around as an example?
So in terms of cost increases, so for example, are they going to, you know, the cost trend growth target, which we've talked about, is a aspirational goal, but there are no penalties for not meeting it. Is that something they would agree that they absolutely will meet over a period of years? Will they agree, for example, and I've had this conversation with them, so I'm not saying something I haven't raised with them directly. There are all sorts of external benchmarks. The Center for Medicare and Medicaid Services has a STARS program. There's a group called the Leapfrog Group that does measures on quality. Will they agree to be bound or strive to have meet certain outcome goals, and will they be transparent whether they do or they don't? And then what's the consequence of not meeting those? Will they agree to an investment, for example, if they don't meet them, to ensure that they do meet them? Those are just a few things. And then what's the oversight? If whatever they agree to, there needs to be some external form of oversight to ensure, because we all have the best of intentions, that they are bound by and continue to be transparent in meeting the types of things they agree to. Will they make investments in the community to ensure access for the underserved, to address social determinants like we were talking about earlier, to help address unconscious bias in delivery of healthcare services. Those are the type of things.
Yeah, so the 3.2% index that we were speaking of right now, we were discussing that it is voluntary, it's aspirational. So you are looking for this application to actually codify that as a cap without any wiggle room. Is that correct?
That could be. I can't. That's just one example that would be possible on the type of thing we would look for them to agree to. The Office of Health Insurance Commissioner has requirements on health insurers relative to hospital increases in our contracts with them. It's on us, not on the hospitals. And it limits the increase to the consumer price index. So, would they agree to some limits on the rate of increase? That type of thing.
Mm-hmm.
So those are very specific things, which have been, there are things in other markets that have been agreed to address these issues.
I'll come back to the unconscious bias in healthcare in a minute. Since you raised that, it's something I'd like to learn a little bit more about. But I'm wondering if the situation in Rhode Island being a very concentrated market, a small state, that exacerbates some of these issues that are in play, right? Because the two institutions together control 80% of the hospital beds in Rhode Island. So that's why it's of prime importance to Blue Cross, because there needs to be some healthy tension there, if you will, when you begin your negotiations and your payment structures. So that's some of the reasons why you have been so diligent in taking a look at some of these trend lines and how it might look going forward. So is it particular to Rhode Island? Would that make a difference in the literature that you've referenced, that Rhode Island is different than other places throughout the country?
It's not totally different. I mean, this is definitely a concentrated market, and I think a little bit unusual when you talk about in terms of 80% of the hospital beds. But this is a trend around the country with hospital mergers, when hospitals that are certainly located near each other and there aren't a lot of alternatives merge, prices tend to go up because there is less competition for services. People, healthcare is ultra local. There's a lot of discussion about people leaving the state. Our data suggests that people go to the hospital to get services, which is less than 20 minutes drive from their home. I mean, that is so, I think Rhode Island being very, one of the smallest states, it is emblematic of what happens in small markets, but it is not just here. And, healthcare is a big expenditure for all employers. And so to the extent it goes up, it crowds out other spending.
The most recent iteration of this proposal before the MOU was crafted between Lifespan and Care New England was that Care New England was going to partner with Partners Healthcare in Boston. Did that combination of factors give you as much pause as this does?
I think, look, it's better when care is local. We know people like to receive care, a short drive away. And so if they can come up with a solution to address these concerns about cost and quality, we would be very happy to have care local. We have a great relationship with both Lifespan and Care New England, and of course with Brown as well. And so if local players can all work together, that's the ideal situation. But there have to be protections in place.
Wondering about the comparing and contrasting. So we're talking about the bringing together, the unification of 3 local players in a nonprofit mode. How would Blue Cross feel about bringing in, or would the situation look different? Or is it preferable to keep it local and nonprofit versus the entry of another for-profit entity in Rhode Island? Which scenario gives you the most concern?
Look, we're for-profit. We recognize, with for-profit, you don't have any shareholders to that you need to answer to, and so that's a real positive in our view. And there aren't profits leaving the state that would go up to, for example, a holding company in another place. And so, from our perspective, that's a positive about for-profit. But there are other hospitals in the state that are not for-profit that we work with and have good relationships with. So I wouldn't say we don't like working with for-profit. I mean, what we care about is providing, focus on the community, providing high quality, cost-effective care.
What does the literature say about non-duplicative services? So silos, doing the same types of procedures. So Care New England performing, cardiac services and lifespan as well, and Care New England performing OBGYN and lifespan as well, and a cancer silo and a cancer silo here. Does the notion of bringing all those services together and increasing volume will that ultimately deliver better care, and also care that is less expensive and more competitive to price?
I think that's the goal, right? I mean, with many things, the more volume you have, the better you get at it, and costs go down on a per service basis. And so I think if Lifespan and Care New England can truly integrate their services and take out unnecessary waste and improve the patient experience, then that's the ideal. I mean, but that's very, very hard to do. But certainly if they are able to accomplish that, a truly clinically integrated system working with Brown, that should help to address cost increases and quality and outcomes, which is better for everybody. And quite frankly, as that improves, the reputation improves, and that's good to attract businesses too, and research dollars, which I know they're interested in.
Yeah. So the research and the medical education component is also very interesting, with the medical school being the primary driver of a lot of the young talent, the residents, and the researchers that are working within our healthcare institutions. What is your understanding of what Brown is saying that they are bringing to the table, and what is President Paxson sharing with you specifically about the role of Brown and the additive value that they provide to this combination potentially?
Well, I think the reputation of Brown is obviously stellar. Bringing an academic medical center, and I know they have all, and I've heard Dr. Babineau in particular say this many times, Rhode Island is one of the only places that does not have an integrated academic medical center. So I think having that is what Brown brings to the table. I know President Paxson has been talking about a National Cancer Institute. My understanding is, there's a lot of work and money that's very hard to achieve, but certainly if they were able to achieve that, I think that would be helpful. I know Brown has, with the draw of the Brown name, bringing in academic researchers who are able to help bring in more research dollars is definitely a draw to this state. And certainly, there's an industry, and I know, Laurie, you've been very involved in that will build up around that. That's a positive as well. And I look, it's great to have Brown at the table helping Care New England and Lifespan think through what does an academic medical center look like, and having residencies in one place, and working with the faculty at Brown, if done right, and I'm sure could be fantastic.
Yes, specifically, you're referring to the development around the medical school and within the former jewelry district of a life sciences campus and a knowledge economy and innovation economy, which has been primarily fueled up to this point by our nonprofit organizations, whether they be our hospitals and also our universities and colleges, in addition to entities such as yours that have a pivotal role to play in divining, if you will, the next generation of healthcare delivery services, not just here in Rhode Island, but across the country, and using, data and other sources of innovation to, drive new discoveries, to drive drug development. So there is, as you point out, a secondary piece of this, which is part of shoring up and growing the fundamental foundations of our economy, and doing that within a bricks and mortar situation in the Knowledge District.
Yeah, it's exciting to think about. Blue Cross is in Rhode Island. We've been here for nearly 80 years. We're not going anywhere. And so we care deeply about this. And if that can grow even further, and a single academic integrated medical center can happen, it will be really helpful for the state, and helpful for all of our residents. At the end of the day, that's the goal. Help improve our goal, to help improve the health of the state residents. And that helps the state.
As you know, you are on our board of directors. We really value your leadership and your participation in all things relative to economic development and the growth of our economy. Some businesses, may, be wondering, the notion of, the healthcare economy sort of is an outlier, if you will. It doesn't follow the normal practices of pricing and competition, because it is an entity, totally unique in terms of our, a slice of the economy. If you were to suggest one thing that employers should keep their eye on in the coming months as this discussion further escalates around a proposed combination, what would that one thing be that you think employers should be most centered on at this point?
I really think it's cost. And I think the most important thing, and Laurie, I know we've talked about this in the context of the chamber, is it's really important for employers to let Lifespan, Care New England, and Brown know that they care, and that they're educated and paying attention. We all need to feel accountable, and I think that is really the important thing, because, as I've said, quality is critically important. But if costs go up and people can't afford to provide healthcare coverage, or can't afford to invest in their businesses, that's a huge problem. And it already, I know I've said this several times, but already crowds out a lot of other spending. So I think focusing on that, and playing an active role in the public conversation, letting the regulators know that it's important to businesses in Rhode Island that be addressed, is critically important. And I think it'll produce a better outcome for everybody.
Mm-hmm. So a lot of employers might say, yeah, that sounds like a great idea, but, what do I know? And how would I go about doing that? And how would I open up a dialogue with the proposed applicants and the regulators and with Blue Cross? So what is the answer to the how?
So a couple of things. My understanding is there will be some public forums up and coming, open to anyone. I believe the Boston Globe will be hosting a few public forums coming up on these very issues. Blue Cross, I know Lifespan and Care New England have a website. Blue Cross also we'll make information available through our newsroom, just some informational pieces. Our goal is to provide information. I think, even participating or listening with the regulators, there will be public hearings ultimately held by both the Department of Health and the Attorney General's office on this. Is another mechanism for doing that. Rhode Island Foundation, Neil Steinberg, hosts a long-term planning commission, and I believe he is going to be hosting a forum of community organizations, those smaller nonprofits that are involved, to get input on their concerns and how best to address that. And so watching for that information will definitely be a way to go. And we are happy to share information as we, through our experts, learn more with the business community and others.
Yes, and the Greater Providence Chamber of Commerce as well will be hosting various forums as well with the principals in this discussion, and hopefully with others that have a real stake in it, including yourself, Michele. And as we get a little further down the road, and we say this is going to be a long process, but by the same token, we're also saying, hey, let's, we got to get to the end of this road, fairly quickly. We're going to do it in a much more expeditious manner than what's occurred in the past. So it's an interesting combination of, we got to do it fast and, get it consummated, but we also have to take our time and do it in a methodical way and make sure that all the boxes have been checked with those that are the regulators, including the Department of Health, the Federal Trade Commission, and the Attorney General's office.
Right. I agree.
One last thing before I let you go, Michele, and that's the question of, you mentioned unconscious bias in the delivery of healthcare services, which I think is a really interesting topic that people might not be that familiar with. Can you tell us a little bit about what Blue Cross is doing to identify such examples and what we all as individuals and consumers might know about this topic to be better prepared and more insightful if and when we see it happening?
Sure, absolutely. I mean, there is data out there, more and more data out there that outcomes, healthcare outcomes for Black and Brown individuals are different than they are for white individuals. And so Blue Cross has actually been talking to Brown University about doing some, offering some training on provider bias. We produced a guide last year on health equity. We also actually have done a number of things. I think our life index helps address some of that as well. There are questions we ask about microaggressions and bias that people have experienced. One thing Blue Cross is working on, because if you look at surveys and outcomes, maternal health outcomes for people of color are much worse than non-people of color. And so Blue Cross is working to have with members of the General Assembly to have a bill introduced on providing doula coverage, because that's one easy example with the data suggesting the differences in outcome. But in terms of pain management, the data suggests it is not the same. We are working, we have a quality incentive program with some of our provider practices. We are re-looking at that and looking at how we can tie some of the incentive dollars to addressing unintended bias in the delivery of healthcare dollars. So it's a really important topic that I know many have spoken about. Dr. Jha, I have heard him speak about that many times, and looking at how the healthcare system can really take a step back and address that.
You are talking about the incentives within the ACO model.
Yes.
Zoom. Yeah. And again, another example of what you, as today's leader of Blue Cross and Blue Shield, is doing to help ferret out the root causes, if you will, of some systemic issues, whether they be cost drivers or equity issues, and not simply being content to be a writer of checks, the payer, if you will, part of the whole reform movement of healthcare being in part driven by the health insurance companies.
That's our goal. I mean, we're here in Rhode Island. We're part of the community. We care deeply about the health of the community. And I know it may sound corny, but it is absolutely true. We try and put our money where our mouth is, and act as a model corporate citizen on that.
You mentioned Dr. Jha, so we'll close out with this. We did have an opportunity to speak with Dr. Jha here on Chamber TV about, 40 or 50 episodes ago. And we were talking about the vaccine, which had yet to come to market at that time. So here we are in mid-March, and we've opened up the vaccination protocol to 60 plus individuals, 60 plus years of age individuals and over. And then we also hear about folks who are maybe reluctant to get the vaccine. So in the final moments we have left, what would you say to anyone out there that's listening? And we are live on Facebook, and we are live on Twitter, and we are live on YouTube. What would you be saying? What would you say to individuals who have a question mark about whether getting the vaccine, whether it be Moderna, the Pfizer, or the J&J variety, if they have concerns about getting it?
Please get vaccinated. Please get vaccinated. That is how we're going to help restart the economy and bring things back. It is free. The government is paying for it. And if Blue Cross is paying for the cost of administration for people in the commercial market, and the government is paying for people over 65 in the Medicare market, it's really important. We are strong, just like the flu shot. Please get vaccinated.
There you have it. You can't say it any simpler than that. So please get vaccinated. And we all look forward to the day when the economy fully reopens. And, as we talked about at the beginning of the program, we may all be entertaining our workplaces in a very different way, whether it be hybrid or some form of hybrid, but we definitely look forward to the day when that is a reality and herd immunity truly, truly, truly sets in. Michele Lederberg, acting president and CEO of Blue Cross and Blue Shield of Rhode Island, we really appreciate you being with us today and all the support that you provide to the Greater Providence Chamber of Commerce and to the business community in general. We truly appreciate you personally and professionally and your leadership. So we will see you again. Thanks.
Thanks, Laurie. Pleasure to be here. Thank you so much for having me, and thank you for all the fantastic work that you've done.
Our pleasure.